venture into the frontiers of healthcare data innovation with the Health Data Forum. Welcome to the Health Data Forum's YouTube channel, your gateway to thought-provoking conversations, cutting-edge insights, and groundbreaking advancements in healthcare data. Join us as we explore the transformative power of data to revolutionize healthcare delivery, patient care, and societal well-being. Embark on a journey of discovery. Delve into healthcare data through our informative videos, featuring leading experts, thought leaders, and innovators. Discover how our global movement, Data First, AI Later, is building a strong foundation for ethical and impactful healthcare solutions. Experience the collaborative spirit. Be a part of our vibrant community of health data enthusiasts, where ideas converge, partnerships flourish, and innovation takes center stage. Participate in discussions, share your perspectives, and join us in shaping the future of data-driven healthcare. Stay informed about the latest developments in healthcare data through our comprehensive video library. Catch up on insightful interviews, thought-provoking presentations, and engaging discussions about the role of data as the backbone of healthcare transformation. Join us in shaping the future of healthcare. Let's harness the power of data to transform healthcare for the better. Subscribe to our channel today and become part of the Health Data Forum's mission and our Data First, AI Later initiative to make healthcare data work for everyone.
We are ready to start, and without further ado, I call into the floor our moderator, Tiago Taveira Gomes, a serial entrepreneur. I'm sure you don't like me to say that, but he is already a serial entrepreneur. He's a medical doctor, GP, that started, I could say, a revolution in the way health data is being used in health. So, wow, it could not be less than the founder of the MTG, our platinum sponsor, and this is very brave to put real-world evidence in the public, in the real world. That's the theme of our conference. Tiago, it's a pleasure to have you here. A round of applause for Tiago, if you be so kind. And also online, the other moderators, Bruna Gouveia. She's the Regional Health Director of Madeira Island. Bruna Gouveia has an extensive profile as a researcher with PhDs and as a person that understands health from inside out, and also particularly a friend that I have interviewed already extensively about the regions, and she has an in-depth knowledge, not just of Madeira health system, but also of the whole of the Micronesia, Açores and Canary Islands and Cape Verde. Bruna, thank you so much for being here with us. Unfortunately, not able to be in presence, but hybrid setup, that's the challenge for us right now. Okay, so I understand you will be doing the introduction of the speakers, and then we have a final round of appreciations from Bruna Gouveia in the end. Thank you so much. Enjoy the session.
This session on the foundational steps for integrating RWE in public health. So it's my great honor to be here moderating together with Professor Bruna Gouveia. This is indeed a very crucial area that I have particular found interest as a medical doctor, family medicine, that we see this kind of very deep integration. So we will have our esteemed guest speakers Dr. Nawin Sona, Professor Ismail Gogenur, and Dr. Osama Elhassan. And I will briefly pass the word for Professor Bruna for a kind word of introduction. And afterward, I will give the floor to Dr. Nawin Sona after a brief presentation of his curriculum. So thank you so much. And please, Bruna, the floor is yours for a small introduction.
Good morning, everyone. Thank you, Tiago. It is also an honor to be able to co-moderate with you this session and also to share the floor with such a distinguished panel. I just want to thank for the opportunity and the invitation to participate in this session. Real world data and real world evidence is a very important topic nowadays, and I'm sure that we'll have a very productive discussion today. And we will end the session with an acquired knowledge, additional acquired knowledge, and especially a vision for the future. That's my expectation, and I will be looking forward to hear about the different experiences and the different visions from our guest speakers. So I will give you the floor, Tiago, and thank you very much.
The presentation on the screen from, I believe, Professor Ismail Gogenur. So thank you so much, Professor, to be here with us. It's a great pleasure. Professor Ismail Gogenur is a distinguished medical researcher affiliated with Zeeland University Hospital and the University of Copenhagen, and has a very long track record on conducting clinical translation research in various areas in surgical and perioperative medicine. And I believe with his experiences, we'll be very enlightened on the topic. So thank you so much to be here with us, Professor. I give you the word for your presentation. Thank you.
Thank you very much for the kind introduction. My approach to this topic will be to give you a use case from the clinical setting. So I'm a colorectal surgeon and heading the Center for Surgical Sciences in Denmark. Our approach has been based on what I would characterize as the clinical problem. So this is the thing I would like to focus on first, and then I will be taking it up to the more generic perspective and describe how we can transfer these kinds of approaches to using registries in order to have it as a big data platform that we can train AI models and then implement them into a real-life clinical setting. So the start is always with looking at the problem in the clinic. I'm going to give you the examples of colorectal cancer surgery. This is one of the most frequent cancers globally. The examples I'm going to show you is, it's based on colorectal cancer, but it can be directly transferred to other cancers such as lung cancer, kidney cancer, or other cancers, because the principle of the patient's challenges is the same. So we provide surgery, but even if we do curative surgery, there is a large group of our patients that will have recurrence within the next 3 to 5 years. At the same time, surgery by itself is connected with a high risk of complications. We see this on a global scale, and the rate of complications is up to 50% of patients undergoing cancer surgery. In a Lancet Global Health report, this was 20% of the patients had serious complications, and going into middle and lower income countries, this is just increasing. So what we want to do as clinicians is try to identify factors in the patient that we can tailor therapy optimally in order to both reduce the complication risk, but also reduce the risk of cancer recurrence. So this is a very important problem, and with respect of the economic burden of complications to surgery, this is definitely a very, very high load in the healthcare budgets globally. So I'll give you just an example of a clinical situation, which is something that is generic for any clinicians globally, that you'll have two patients with exactly the same disease and more or less the same risk factors. And as a standard, if I may say so, a clinician, it might not be obvious whether it is the 85 years old female or the 56 years old female that has the highest possibility of having complications. They more or less have the same risk profile with hypertension, a little bit overweight patient in the patient number 2, but that's a younger female. If we use our AI model, we can see that the 1-year mortality is actually doubled in the younger female compared with the elderly female. And these are insights that are brought to us through collective digestion, so to speak, or calculations based on national registries. And I'll give you the example of how we went from the data source and to implement this in a clinical setting. So what we wanted to do is to use our national registries in the Scandinavian countries. This is a quality in the healthcare system where the global representativeness of the patients are tremendously high. So for cancers, we have 99.5% of all patients with cancers registered in national registries, including treatments, so medical treatment, including blood samples, and all these data are connected to a unique healthcare number for each individual. So what we want to do is then saying, if we got a prediction model that could aid us in targeting risk factors for patients, how would we use it? And this, I think, is somewhat maybe trivial to discuss, but at the same time extremely important. With this new revolution in healthcare, we are seeing a lot of good initiatives from the industry, but without involvement of the clinicians, I do not believe that we will have the benefits for the patients. And that's why I think it's extremely important when we identify areas that we need to improve, that the clinicians are involved and come with a solution for, if we, for example, make better predictions, how would we like to use it in our daily clinic? So if I had a model that could predict 1-year mortality, how would my actions as a clinician be if I had a good model? So what we started by doing was taking 4 registries, and this is exactly the same discussion as there was in the first session this morning, that we need to harmonize data. And what we did was harmonizing the data to the OMOP Common Data Model, which provided us a scalability solution and a solution for the GDPR. So what we do is we have mapped more than 150,000 codes into this OMOP Common Data Model, ensuring that the language that we have for our data is transferable to my colleagues that we are collaborating with in Norway, in Netherlands, in Australia, in Germany, in Japan. So we can say we can actually share very vital information about our populations without giving data away to each other, but just by validating with the codes. So we can send our codes to our colleagues and they can run it in their population, and then we can train these better and external valid models and even make the basis for federated learning. What we also are doing are using the open source platforms in order to do analytics and also to reporting our results. So a lot of the work is looking at the source data and mapping the structure and the contents. What we did in our unit was actually to involve our clinicians in the content mapping, clinical Ph.D. So I had around 6 to 7 Ph.D. students in full time going and running through these codes and making sure that the mapping procedure was precise in order to prevent any misunderstandings in the automated mapping platforms that already exist there. For example, I'll give you an example. We have a classification here on the left side, which is called malignant cachexia, which is in the Danish vocabulary. And if we look in the closest ICD-10 match, it is actually a completely different condition, malignant neoplasm, primary site unspecified. So having this translation and making sure that we have proper data and proper quality of the data, as also the first speaker in the morning was highlighting, I think is vital if this is going to hit the clinic, so to speak. So we use the Danish registries, we mapped it to the common data model, and then we trained a model to predict 1-year mortality. And you might ask, why did you do this? So a patient undergoing surgery, those patients that has a higher risk of 1-year mortality is also those patients that has the highest risk of complications. So our aim was to reduce the risk of complications. And then we developed this model, which had a good performance, good calibration, and it was kind of ready for prime time, where we said, okay, we want to stratify our patients to less than 1%, 1 to 5%, 5 to 15, and more than 15%, and then act accordingly, so to speak, give a tailored therapy to our patients according to their risk of 1-year mortality before surgery in order to reduce the risk of complications after surgery. So what we did was going through our registry data, we trained our models. In the beginning, we used lasso regression for our first implementation. Now we are using a neural network model. The important thing here is that we use the registries, we develop our training sets and our test sets, and we could actually see that our assumption of having a higher risk of 1-year mortality was correctly separating patients in higher risk of complications. So the lowest risk group had the lowest rate of complications, readmissions, and mortality, and the highest risk had the highest. So this was then validated in an out-of-sample, out-of-registry data set where we went into our EHR platform. We use Epic in our region, and we then took the data from the Epic and but validated that the registry-based AI model was actually producing the same performance in our external and Epic-based validation set. So what we did clinically, and this has nothing to do with AI, but is directed by AI, we did intensified preoperative treatment of these patients, training them, physiotherapy, aerobic, anaerobic training, protein supplementation, nutritional supplementation, geriatrician, etc. And during surgery and after surgery, we could more closely observe those patients in the group C and in the group D that had higher risk of 1-year mortality. So our data has not been published yet, so it's in publication, and so please do not share. This was our 200 cases after we implemented this 1st of February. Now we're up on almost 400 cases, where we have shown that after implementing this system, we have reduced the length of stay of patients with colorectal cancer surgery. We have reduced readmissions. We have reduced medical complications and reduced serious complications. And these are all statistically significant reductions and clinically significant reductions. For example, for medical complications, that was reduced from 28% to 17% and was statistically analyzed in a multivariate comparison, including controlling for periods of the research. Regarding cost effectiveness, and this will be my last couple of slides, we also made a model to examine how much do we actually reduce the cost by putting a patient into this stratified implementation of optimization. And we can actually show that we spared the hospital system from diagnosis to 30 days after surgery almost 2,800, almost 3,000 US dollars. This is actually just underlining that complications are extremely expensive, and the use case of doing interventions in order to prevent complications is something that is sound thinking with respect of improving healthcare. So now the next step for us is scaling up. So now we're implementing this in all 5 regions in Denmark, in 7, actually 8 hospitals. And what we're doing now is we are taking a user interface in between the doctor and the patient, where we enter the features of the model. And then we are examining now in a randomized clinical trial whether the algorithm by itself is more efficient, is better in allocating patients to these different treatment trajectories than someone like me, so a clinician. And I think that this kind of research is important in order to establish firm evidence that AI, machine learning, can aid us in clinical decisions in the everyday clinic, real life clinical setting. And the last 2 slides is here just to give a thanks to all the good researchers from Center for Surgical Sciences and our clinicians. Thank you very much for your attention, and I would be happy to take questions.
Thank you so much for the presentation, Professor. I have to say it's very inspiring to see the work that you are doing in translating actual evidence into clinical practice and in impactful ways, not only from the clinical side, but also from the economic perspective. So thank you very much for your presentation. And now I will give the floor to Dr. Nawin Sona, which is a seasoned and visionary leader serving at the Secretary of Government of Public Health Department of Maharashtra. I'm sorry for the difficulties in the pronunciation. And that has been leading in the public administration many initiatives aimed at strengthening healthcare systems across the state, and with high leadership of strategic planning, inclusive governance to ensure access to quality health services to the population. So thank you so much. It's a pleasure to have you here with us. And I will give the floor to you, Dr. Nawin, to learn more about your work. Thank you.
Thank you so much, and good morning to all the participants in the Global Hybrid Summit. And it's indeed a pleasure to be part of this. And special thanks to Dr. Paul and his team. Shifting from what Dr. Ismail just presented, I'm a career civil servant with the government looking after public health. The approach to getting real world evidence into practice is a very complex challenge, and I would like to present the roadmap which India has been building for the last 5 to 6 years. It's a very ambitious plan, and Maharashtra is the state where Mumbai is located, one of the most advanced cities in India. And I will walk you through the vision which our country is rapidly building a whole health information exchange. So, learning from so many systems across the world, India's now have a digital roadmap where we are mapping all the citizens, all the healthcare professionals, be it doctors, paramedics, and health institutions, onto a single platform. And the citizens are also given the complete rights to their own health records. So very recently, we have got keeping up with the rest of the world, we have a Data Privacy Act, in which the health data privacy is also rested with the citizen. And most importantly, we look at a consent framework in our country. What I mean by that is the ownership of the health data is definitely with the patient, no matter whether the collecting agency is private or public, or it could be a hospital or a diagnostic center. The ownership is with the patient, and what the country is building is a consent network, a complete data layer which is interoperable. And suppose a patient has a health record with a private operator and wants to shift to a public space, the explicit consent on a data level is required, and this is the guarantee given by state, right? So this is a very new approach what we are taking, and very recently, Hospital Health Standards Authority, which is the National Accreditation Board, has come up with a document empaneling hospitals with digital standards. Not only clinical standards, but we have a separate layer on digital health standards, and they're separately certified by a national authority. And the incentive is the crux. As a policymaker with more than 25 years of work, I feel one of the greatest challenges for pushing digital health in a complex country like India with multiple stakeholders is whose data is it, and who's going to use it, and for what purpose. So where I think as policymakers and stakeholders, one of the great approaches we should look at is the technical part, which is the clinical technical part. Like, we all of us have the knowledge of SNOMED ICTs, or Leonic standards, or ICF standards, and mapping. And yes, that will be interoperable. But there are emerging tech like wearables, right? Where it is still a lot of regulation and standardization is a big challenge. The third area which I look at is software as a medical device. So at a global level, this is something like, is an AI model a medical device? Is a big question. So looking at, we have a black box approach to AI and machine learning models. How to standardize those? So that's a big challenge which we are taking up in India. And the other aspect is, of course, at a policy level, how do I incentivize the players in the system to adopt this? Now, as a cancer registry, I think it's a great use case for cancer. We have National Cancer Registry in India also, so we have tumor registries and so on. But what about other diseases? So the burden of other non-communicable diseases, emerging diseases, which are constantly evolving. So I see a huge use case for emergent diseases, rare diseases. Have we discovered all the diseases which are to discover? I think not. So there are new variants, as the epidemic pandemic has shown us. So real world data is going to push the envelope on really understanding public health, but the difficulty lies in how to incentivize a private player to share data for public use as a public good, which I think as global governments, maybe as the WHO or the global think tank, we need to come up with a model to incentivize this outside of economy, a health economy approach. Who's the demand? What is the demand, and what is the supply, and what is the incentive? I think is a very crucial question all of us have to decide. At a data level, I think challenges for our countries are also huge. The bad data sources have to be validated, certifiable sources, so which is again a challenge. But I think it's extremely positive results wherever we have used real world information into our systems. It has given fabulous results. And one major aspect which I'd like to share with you, Maharashtra is a big state geographically and population. We have a population of 130 million citizens. And I'm glad to say that we have a universal healthcare policy, which has brought almost 100 million citizens into our registry, right? We have given individual identifications, and this is an insurance-based model. So through a global summit like this, I see a grand use case for getting into a lot of data analytics. As it said, is data is the new oil. So we are sitting on a lot of unrefined data, and it's a gold mine of clinical data of patients' trajectories in the health system. So we are trying to set up a health analytics center with the state, which would mine through these data. And I think more and more data is going to come. It is a big data challenge, and that's a very positive development within our state and our country. And lastly, I would, of course, want to bring about the beauty of AI and ML for a country like India. So we have 22 official languages in our country, right? And these are regional areas. Seldom do we understand each other's languages. So AI and real world translations for our clinicians. So there's a lot of information which would make everyday usage of data more meaningful for our doctors through natural language processing, through image processing, text to voice, and so on. So data is not less. It's how the government is going to encourage the full usage of available information and making it more insightful, I think is the biggest challenge. And the major future, I would say, is only one thing from a tech perspective. We are hearing a lot about simulation, right? So we have a digital twin or versus a simulation models. So where does real world evidence or real world data fit into a larger world of modeling based on simulation? When I say simulation, it would be for drug discovery or disease profiling or for clinical decision support. So how much of real world information is going to be relevant for an AI model to build something usable, which is a critical level. I think it's $1 million question. For more robust AI models, as was seen earlier, we should encourage real world data, which only brings me to ethical AI biases in data collection. So our government is also very keen on putting in safeguards on ethical uses of AI and also anonymizing health data, which I think is a crucial part of the whole system. So you give the confidence to the people to share their information without fear of misuse or data leaks or any such hacking, etc. So the topic is very vast, and we do look forward to getting more participants of such forum into our country. And on behalf of Government of Maharashtra and India, I welcome all of you to reach out to us, and we'll be more than glad to have you over and look at our systems and help us improve this wonderful journey on getting real world data into health. Thank you so much.
Thank you very much, Dr. Nawin Sona, to learn about the reality, challenges, opportunities, and how important these topics also play a role in your region. And we will have time for discussion in the end. So now I would like to call to the floor Dr. Osama Elhassan. Dr. Osama is a prominent leader in digital health innovation, currently serving as the head of digital health at Dubai Health Authority, has extensive experience in healthcare and digital transformation, and his work has been instrumental in shaping the future in health services in Dubai and quite honest also around the world. And I also have to say that I was very fortunate to meet Dr. Osama Elhassan very recently and get to know his work on the ZIMAM and the GCC Task Force on Workforce Development in Digital Health. And so I welcome you to the floor, Dr. Osama, and for sure will be very enlightening with your presentation, which you already know that the work you've been doing is serving also as a great inspiration to what we're doing. So very pleased to have you here with us.
Thank you very much. So my name is Osama Elhassan. I'm a software engineer by training. However, I carry more than maybe 18 years of experience in digital health. I started to encounter digital health back in 2007, 2008 during my PhD, when I was doing a PhD on socio-technical systems. So we thought that the healthcare is the best example of what we call socio-technical systems, where we need to model human interactions and where we have the ability for humans sometimes to break the glass and do things against the norms of the system. So that was my starting point. After finishing my PhD, I decided to leave academia and join healthcare ecosystem. So I joined Dubai Healthcare City in 2009. Spent there 3 years. I was part of the team who developed the first health information exchange platform. After that, I joined Dubai Health Authority in 2012. I was part of a small team who developed the digital health strategy for the city, which included building a regulatory framework for digital health and also building a health information exchange across the city. So across my work during the last 18, 19 years, I realized that one of the biggest challenges that we have in the digital health domain is that we lack professionalism in general in digital health. Many people comes to the digital health arena trying to carry their expertise in different domains and try to apply what they learned in banking, for example, or in municipality management to healthcare, and almost they fail. And the reason for that, because they don't understand the special cases that we have in healthcare. Dealing with doctors is different than dealing with customers in other domains. So we need to understand the essence of healthcare, how healthcare works, and then try to learn and then to apply digital transformation within healthcare. So we thought that we need to add some professionalism to the digital health domain. So because of that, I decided with a number of colleagues to develop a full-fledged NGO that focuses on building talents of digital health by building what we call competency-based framework for digital health. So when we came up with ZIMAM, so our vision was to build a talent-centric path for digital health sustainability. We think that to sustain digital health domain, we need to have empowered talents. And those empowered talents cannot be empowered without having good job descriptions, good competencies, good career path. Otherwise, you will lose all those talents. Yeah. So our mission was to cultivate future-ready digital health workforce through continuous training, knowledge transfer, and building a competency-based career path development. Facilitating international and regional collaboration through fostering exchange of experiences between countries. We know that many of the problems that we are trying to solve today have been already solved in other places. So why don't we learn from them? Establishing digital health platform to empower talent for multiple relevant domains through cross-border digital health credentialing programs in collaboration with leading digital health professional organizations. So we need to bring all digital health professionals together to build some sort of training programs, to certification programs that can be informing the career path that we want to build. So we started ZIMAM in 2018. We started with a very small scope, which is GCC countries. Now we are enlarging the scope to catch up Middle East and also working collaboratively. And by the way, we decided to register ZIMAM as a full-fledged NGO, not in the GCC, but in Geneva, because we think that the message that we have, the mission that we have is an international demand. It's not only a local demand. So across the years, we managed to develop a fully recognized event that called ZIMAM event that happens once a year. We bring all like-minded people who are really fostering better digital health community. So we bring them all together once a year in our event in ZIMAM. We built the first competency-based framework that was targeting GCC now. That started in 2017. We published almost like 5 or 6 papers around it. Now we want to extend this to be kind of an international competency-based framework. We developed ZIMAM Awards. So the idea behind ZIMAM Awards is to cherish, is to celebrate success within digital health, best practices in digital health across the MENA region. That was a very welcome way of bringing people together through competitions. So we have an award with 12 categories that celebrates either personal, organizational, or even project-based achievements. So I think maybe 2 weeks ago, we had our award ceremony. It was very, very, very energetic, and it adds a lot of energy to the domain. We developed also the first survey around competency-based framework in the GCC, where we collected almost like 600 responses to understand the challenges that we have as a healthcare practitioner. So one of the key things that we identified was really, really alarming, that we realized that almost 78% of our cohort of responses, they mentioned that they pay either fully or 68% of them, they either pay fully or partially for their on-the-job training. So even their employees are not supporting them. So that's just one example on how we see that even core pillars of acquiring and reserving your talents is not there, which is the on-job training. So we need to do a lot of education around that. So what we are trying to do after building our competency-based framework, one of our core objectives is to develop what we call the competency-based platform. It will be kind of a LinkedIn for digital health talents, but it's not more, but it goes one step behind that by identifying the cohort of people that we're trying to targeting, which is healthcare workforce, digital health workforce, and leadership. So those 3 groups need to go through kind of like upskilling, cross-skilling, and reskilling processes. And these exercises will be through tasks, through certification programs, through even projects. But all these projects or certification programs are actually mapped to our competency-based framework. So today, if I am a physician who wants to be cross-skilled to be an AI citizen, for example, so what kind of work for training, certification I need to that? So I need to have kind of attested certificates, and not only attested, but also mapped to the competencies that are compulsory for me. So this is exactly what we are trying to do through this platform. And the target always will be building new opportunities for those cohorts to be digitally skilled workforce, or to be digital health experts, or to be consultants or freelancers, or even to start their own startups and entrepreneurship. So this is what we are trying to do in general. We built now a huge, can say we have almost like 6 different research groups across Australia, UK, US, who are supporting us in building this competency-based framework. And we are happy to join, if anyone want to join us in this long journey. It's not an easy job. So that's it. Thank you very much for your time. This is part of the partners that they are already working with us now, and we are looking for more here. Thank you.
Thank you so much, Dr. Osama. Indeed, this area, which is so interdisciplinary, And in the topic of what you're discussing, of moving RWE into the public health sector, for sure, we need capacity building to get there, to create the means for all this knowledge, all the data, all the algorithms to actually translate into the real world. So now we will have time for questions. I will.
Hello, I'm Lisbeth Siderius from Netherlands, and I'm really impressed what is happening in India. Such a huge country, and your government is putting a lot of effort in making digital health work. And I also really like to hear that you are also implementing the ICF. Is that really implemented in the systems also by the governmental agencies? And for a speaker from Dubai, I really thank you for your presentation, because I really see the need of pediatricians or other specialists to get to know more about digital health. So can you make a program for pediatricians, global pediatricians, and can we collaborate on that? Because there's a gap between practice and IT people, and we have to overcome that gap.
Thank you very much. I will firstly pass the word to Dr. Osama while we wait that we get the Zoom speakers back on the screen, please. So there is also the...
I understand you make educational programs for doctors.
So the educational
CME accredited programs?
Yeah, so the educational programs has like 3 types. So the first one is working closely with universities who are developing degrees.
Yeah.
So making sure that our competencies are part of their curriculum.
Yeah.
So that's one way of, so we support universities to make sure that the outcomes of their curriculums are matching the needs of the market. That's one thing. Second thing is working closely with knowledge bodies who are developing certification programs. So one example for that could be HIMSS or EMEA or AHIMA. So they develop certification programs, like, for example, for coding or for cybersecurity in healthcare, whatever. So we make sure that the contents of their certification are also matching our competencies. The third element, which will be the projects done on the ground. So, for example, being part of an EMR enrollment in a hospital. That itself is carry a lot of competencies by default. So putting this in your CV and mapping it to your competencies will also add value to it. So these are 3 elements.
So my question was, could you make such a program, or could we together
make... We are not developing it. We are just mapping, making sure that our competencies are mapped to those programs. We inform those programs, but we're not developing.
Before moving, there was also one question for Dr. Nawin, yeah, from the comments.
Yeah.
So if I can pass over to you.
Yes, thank you so much for appreciating our work in digital health. So in India, of course, the various data standards have been in place, including ICF for hospitals. There is a lot of difference in how these standards are adopted between the private and the public domain, public health hospitals. So quite a few of the standards are voluntary, and they are used as incentives. For example, in our state national insurance model, where the state completely pays for the premium, and it's a cashless treatment for secondary and tertiary care. So it's a very handsome package for most citizens. But the payment to the hospitals is 10 to 15% more if they adopt the standards, be it health standards or now we are introducing digital health standards also. So we use these standards more not as a regulatory aspect, but more towards an incentive-based model. And however, we hope some of the more corporate chains. So in India, a lot of faith is kept on huge corporate hospitals and their chains, and they are coming online. So which is a great thing, and they are industry leaders. Of course, the distribution of healthcare system in India is very skewed. You can say it kind of a fat tail kind of distribution where there's enough space in all the kind of services. So we are reaching there. Um, However, just to divert a little bit, with the privacy coming in, we are going on a different track of putting a lot of punitive aspects for data breach in privacy. So one side it's incentive based, including financial incentives, and one side there are huge penalties for people for who breach patient data security. So somewhere in the middle is our approach. And yes, we are trying to fit all of these standards into our healthcare system. And of course, it's a now we are on a platform-based model, like say what Apple was doing or a Google Play Store. So now we are opening it up for on a certification and a platform-based model. So the National Health Authority certifies the health services, be it EHR or EMR or a laboratory management information system or health applications. They are certified by our National Health Authority on digital standards and security standards, and it's an open market operation. So anybody's allowed to buy anything, and we are kind of gatekeeping on the standards. So standards are very important for us, and we are trying our best to push it into even the private market.
Thank you so much, Dr.
Thank you.
Elhassan, for sharing. Now we'll pass the.
Yes. Peter Villax for the speaker, Maharashtra State. Sorry, I can't read your name. You made an incredible presentation. I have two questions for you. Number one, a few years ago, India started the development and introduction of an extremely advanced national identity card system for 1.2 billion people, which is incredible. Is the national ID integrated with your health data system? Number one question. Second, you talked about privacy. Privacy means confidentiality. Can you talk to us a little bit about what you have implemented in terms of privacy measures and confidentiality protection measures?
Thank you so much for your kind words. I'm Nawin, Secretary of Health of Maharashtra. So regarding the first question, yes, the National Identity Project, which is the Universal ID, what we call Aadhaar, AADHAR, Aadhaar is the name we have given. So I'm very happy to answer positively to that question. So the health information system India is building is completely based on that unique identifier that we have given our citizens here. So what we have done is use that UID, the unique identification number, as the base and build the health identification on top of that. So if I say there are 120 million citizens mapped into our insurance program, their base information is this unique identifier. And we are adding another layer of health identification, and which is also, we call it ABA, which is an acronym for a health account. So on building of a unique ID, which is, let me tell you, everyone uses it multiple times a day for financial transactions. Every QR code used in the country, we have gone from cash to a largely cashless economy thanks to this merger of unique identifying and the banking system. All our ATMs are interoperable now. So based on that payment gateway, we are building a health information gateway which is interoperable, and this health account is also event based. So where suppose a person is going to a health event for a diagnostic event or a treatment, and all this data can be pulled through this unique health identifier, which we call ABA, AABHA, is a health account which we're building on this. So that's a very ambitious project, and we are rapidly progressing on that. Regarding the second question on privacy and confidentiality, so we have, I'm glad to announce that there's a national act which has been passed, which supports this health privacy, and which gives the developers and users, for example, the private hospitals, labs, health application makers, stringent guidelines on data storage, and on usability, along with the consent framework which our digital health authority is building. So we have the legislation on one hand, and we have the IT layers being built on this parallelly. Both together are going to help citizens rest assured that whatever data they have in their private hospital or public hospital is not going to be misused. And if they want to, suppose if I'm a patient and I like to give my data for clinical research, I could do that with a simple consent mechanism, and where my data would be anonymized and it could be part of a research project. So this is the very ambitious framework which we are building, and I'm happy to share that major private hospital networks are already very gung-ho on this, and they're coming on to these standards. And I'm going to see in the next year or two a transformational change in the way citizen is going to store and use their medical and health records. And I would gladly invite all of you to visit us and learn more about this. Thank you so much.
Thank you so much, Dr. Sona. We are a few minutes over the time, but I think we still have time for at least one question. I will give the floor to Professor Salim. Yeah.
Yeah, thank you. So my question is to Nawin. Nawin, the government of India is doing fantastic job when it comes to healthcare and in providing healthcare services to people. So great work. My question is around fraud prevention. So when you talk about insurance coverage, and when you talk, even you say that you have 120 million people enroll in your insurance program. So one of the modalities that you have is telemedicine, virtual care. So when people are using virtual care, how do you prevent fraud from happening? And what are the best practices that you have implemented? I would love to learn about that. Thank you.
Yes, thank you so much. So it's indeed, I'm glad you have mentioned fraud prevention. Every single case that the insurance payment is made from the state exchequer, which is taxpayers' money. And in government, we are at the national level, we do have a national anti-fraud unit which runs cutting-edge AI models on all kinds of fraudulent practices, which encompasses, starting from fabricated medical records or X-rays which people have copied from the internet, or one X-ray being used for multiple patients, or male patients having female procedures being done on them, and so on. So even at the state level, we are in the process of building a cutting-edge AI-based anti-fraud unit. It looks at image processing, NLP, handwritten text to convert it to XML and so on. So we are using a lot of cutting-edge tech to tackle this problem. Similarly, for the telemedicine is a very popular thing. There's a state-run telemedicine program. We have millions of people coming onto it. But I like to say that the telemedicine network is much more robust, mainly because we do immediate, every telemedicine patient coming onto our state network is mapped onto the unique identifier, and a health record identifier is also created along with that. So we have a wonderful tracking mechanism for all our citizens who are coming on the telemedicine network. In fact, that's a flagship way of creating health records, because that's much more robust. And of course, the issues are in not in the treatment but the diagnostics. So we have very federated lab records. So now we are slowly converting all our lab records into digital space, and digital standards are being pushed into our empaneled private vendors, so that our clinical decision support system and our diagnostic support system are both equally digitized and have the same security network, and our patient identifiers are going to be at the diagnostic data also, so that it's traceable. We can do audit trials, we can do anti-fraud even on our diagnostics, which is also a huge payout for the exchequer. So we are building various approaches at each stage: diagnostics, at clinical level, at patient level, and also the facilities which provide and the doctors who provide these services are also mapped onto our system. So if you come after a year, we'll be probably able to open up a GIS model and show you all our patients mapped on a geography, all our hospitals mapped on a geography. We'll be able to show you the kind of facilities we have, and that's the kind of visualize services that data is going to provide us. So we are on a very ambitious path, and thanks for that question.
Thank you so much. I will pass for the final question before giving the floor to Professor Bruna for the closing statement. So, Mariana.
Yes, I'm sorry. I know that we have to be brief, but I had to ask a question to Professor Ismail, just so that you know. My name is Mariana Paes. I am from MTG Research and Development Lab, but I am a general surgeon by training, so that you understand my particular interest. And I would like to know what kind of specific challenges you find when trying to apply these translational projects in the sense of the clinical acceptance of these, and if you have some advice on how to scale and implement these kind of projects. Thank you very much for your presentation and your sharing.
Thank you for the question, and this is it's a really vital question. So the first and simplest answer is co-sharing or buying in. So you get the stakeholders involved in the process, and in this particular case, the most important stakeholders are the clinicians. So the barriers that we need to solve on the data science infrastructure is on the harmonization of the data, setting up an infrastructure that can be scaled across the country. So this is the more on the IT infrastructure. When we're developing the models, what we did was to include our clinicians in the work together with the data scientists, and making sure that the clinicians had, by design, an explainable model that was served for them in the clinical setting. So the implementation of the algorithm into daily clinical practice was really aided by a co-ownership from the most important stakeholders. So this was, I think, the reason why we actually had a very successful implementation. And I think that several of the speakers before have touching upon the maybe the lack of insights into these new approaches from those that are going to lift it into clinical practice. So continuous education, understanding the power and the limitations of predictive modeling in clinical situations where we take decisions on patients' care, I think is some of the maintenances that we need to do when we are running this in a clinical setting. But the shortest answer is co-ownership and inclusion of those that are going to use the models. And I think this is one of the translations that what we need to be attentive of when we are getting industry to provide products is this validity of both implementing models that have been trained outside the country that we are using it, and secondarily, whether it has passed the test of having pilots where these models have been successful. So I think this is one of the major challenges, but is something that is also being having proper attention and something that definitely can be solved.
Thank you so much for the valuable insight, Professor Ismail. So now I will pass the word to Professor Bruna for the closing remarks of this very fruitful session. Please go ahead, Bruna.
Again, thank you very much for giving me the floor. It's after this very interesting discussion. I guess I will be very brief in this approach, but I cannot close without speaking a little bit of what we've been discussing this morning. First, our first speaker, Professor Ismail, has talked about how can we benefit of real-world data on health practice. The truth is that we know that the findings generated by the analysis of real-world data can help inform care and can help decisions on treatments, data-driven decisions. And that's what we've seen when Professor has described the approach to the Danish health data registry. He has talked about harmonization, and that's also a challenge in several places because gathering data has been done for a long time, and the truth is harmonization is also a challenge. The transfer of knowledge using AI models, and Professor talked about the model to predict 1-year mortality, is very important, and he has shown as it was useful for implementing more effective interventions in clinical practice. I guess that our guest speaker gives us two main home messages: that real-world data is the key for identifying factors and tailoring interventions to prevent recurrence of events that are negative for our patients, showing the benefits, the healthcare benefits of the use of real-world data. Also, I would like to mention the idea that Professor Ismail has given us about the participation of clinicians in this process, which is really very important, and they've shown that it makes data more useful in this process of producing real-world evidence. Thank you very much, Professor Ismail. As for our second speaker, Secretary Nawin has given us a decision maker's view of this situation and has described India's approach to routinely collect data relating to patient health and healthcare. Our speaker has mentioned how the setup and the use of health data records are being done, and mentioned especially the challenges this process has brought to discussion. Consent is naturally something that accompanies health in every step of the way. And when we're talking about the use of data, consent is really important. And our speaker has spoken about defining standards and defining and knowing every step of the way whose data we are talking about and who is going to use it and for what. Also, Secretary Naim has spoken about quality of data, and this brings us to discussing data sources and the importance of having valid and certified data sources. And related to data sources, there is the challenge of mobilizing stakeholders to sharing of data. This also a challenge that we can see in our regions, because we have the private sector with different data sources, and we have the public sector. It is easier to make the public use of public resources, but bringing everyone together is a challenge, and mobilizing stakeholders for sharing data and also for granting interoperability is really important. This is also, besides this challenge of mobilizing stakeholders, Secretary Naim has mentioned also managing heterogeneity, the need of uniformization for full use and full benefits of data information. This comes along with the idea of Professor Ismail of harmonization of data collection. So we can see that challenges in decision-making and in practice are really along with each other. As a last topic, I think that Secretary Naim has launched a new discussion that would give us, would need us another session and several more, which is ethical issues related to the use of AI. And this is also a concern that has to be accompanied and discussed additionally in the future. But I guess that our next speaker, the third speaker, has given us some practical answers to the challenge that we have been talking about. And Dr. Osama has shown us that besides the relationship between real-world data, real-world evidence, the collection, the analysis, and the application of data is complex, and it requires a great deal of expertise and innovative technology and competences to fully harness the power of using real-world data. And Dr. Osama has shared a view of how we face this challenge. The truth is that this digital transformation and prospective transformation on data health records has been very fast, and we lack professionals with the needed expertise on digital health. And I think that's a shared concern from different locations. So it is important to build talents in digital health to grant sustainability for this process, and also quality in what we're doing. And our guest speaker identified some strategies, and I guess we are contributing also with the this global forum for this strategy. Promoting events to call and promote talents and promote partnerships is important, and also to highlight and identify good practices. And our Dr. Osama has spoken about prizes, awards, but good practices have to be known, published, presented for everyone to be able to improve their own process. And focusing on competences. Our speaker has spoken about building a competence platform, and that's really important. And I would like to highlight also the importance of different approaches to this building of competence in the area of digital health. And upskilling, cross-skilling, and reskilling was mentioned as one of the solutions, and that's really important. And it's, again, crosses the idea of Professor Ismail has spoken about the participation of clinicians in this process. I guess the health professionals are really interested. Our someone commented and asked about if they can participate. I guess there is a lot of opportunities for upskilling and cross-skilling and reskilling in this area. I guess that all the interventions were really very interesting. We had very interesting points of view, and we've confirmed the potential of the use of real-world data. We had a lot of ideas to discuss, and I'm sure that we will be able to do that again in the future. I would like to thank you everyone for their participation, and I expect that we come along this way with additional experience to contribute for great improvements and better use of real-world data in health practice. Thank you very much.
Thank you so much, everyone.
Everybody's looking for a healthcare system they can trust. In the age of AI, transparency and ethical data practices are revolutionizing healthcare. By ensuring that data is handled with care, we build trust among patients, healthcare professionals, and stakeholders. Why does this matter? Ethical AI ensures that every decision made is aligned with human values, providing accountability and eliminating bias. This means better outcomes for everyone involved. But it's not just about technology, it's about trust. When patients know their data is safe and used ethically, they feel more confident and engaged in their healthcare journey. Let's embrace transparency and ethical data practices, because a trusted healthcare system is a better healthcare system. Transforming healthcare, one ethical step at a time.